and welcome to our lesson on acute coronary syndrome. So, what do we consider acute coronary syndrome, or ACS? Well, it refers to a triad of conditions: unstable angina, non-ST segment elevation myocardial infarctions, NSTEMIs, and ST segment myocardial infarctions, or STEMIs. It's important to know the differences here and the treatments for each. So, any one of the three can present with chest pain. In unstable angina, the pain that the patient's feeling, it's really unpredictable. It can be intense, it can happen at rest or activity, and it's really difficult to relieve. Usually with these symptoms, the patient's coming to the hospital. They're seeking out treatment. With any of our chest pain patients, we want to do two things. We want to get the EKG and cardiac enzymes. That's the blood work, right? If we see ST depressions and positive enzymes, that's probably going to be an NSTEMI. If we see elevations in two or more contiguous leads, that means next to each other, we can assume they are having a STEMI, the big one. That is a complete occlusion of a coronary vessel. And in this situation, many facilities are now calling for a code STEMI, which activates the cath lab, activates the STEMI team. Check with your facility about that. So here we have an inferior wall STEMI, ST segment elevation MI. So if you look here, you can actually see those ST segment elevations in leads 2, 3, and AVF. It's often referred to as a tombstone sign. And if you look, well, that kind of looks like a tombstone, right? Kind of that squarey rectangle. Either way, we see it in contiguous leads, 2, 3, AVF. This right here, that's a STEMI. That's bad. Get them to the cath lab. So when it comes to presentation, there are some very common signs and symptoms, and there are some that are not so common. Traditionally, we are very textbook. The men, the guys, we present with the symptoms we know and love, the very textbook stuff. That chest pain that starts in the middle of the chest, radiates to the jaw, radiates to the left arm and down the left arm. Guys are easy. Women, on the other hand, it may not be as cut and dry. Many simply complain of not feeling well. Something's off. They can present with nausea, abdominal pain, dizziness, diaphoresis, really a host of other symptoms. And the problem is we may not attribute these to being cardiac in nature. So guys, when in doubt, never hesitate to grab the trusty EKG. It's not invasive. It takes seconds. It doesn't cost anything. Get an EKG on these patients. Now, when it comes to kind of getting the history of what's happening to the patient, we like to use the acronym Old CARTS P. And what that stands for, and we'll go through it. So onset, when did the pain start, right? Location, where are you having the pain? Chest, jaw, arm, anywhere else. Duration, how long have you been having the pain? And is it consistent or does it come and go? Is it intermittent? Characteristics, what does it feel like? This is where we hear a lot of those patients say things like, it feels like an elephant is sitting on my chest, or it's crushing chest pain. So we want to know the characteristics. Aggravating factors. Does anything you do make it worse, specifically activity? I want to know if you get up and walk, it makes it worse. Or if you were mowing the lawn, it made it worse. Relieving factors. Anything you do make it better. When you sit down and relax, does the pain go away? Treatment. Have you done anything for it? Did you take any meds? Did you take your own nitro? Did you take some aspirin? We want to know that. Severity. Simple, 1 to 10. The thing about this, guys, is obviously we know pain is subjective. You've heard about it in other lessons. You've dealt with it with your patients. When I do this, 1 is relatively no pain. 10 would be as if I was sticking flaming needles through your eyeballs. It's a little graphic, but you can imagine that would hurt. It's a little easier with women. 10 is childbirth. I'm assuming. I've never had children, as far as I know. Yeah. So for women, 10 is the pain of childbirth. If they had kids, they know what that pain is. For guys, come up with something like, I light you on fire and throw you off a cliff. I don't know. But you want to be specific, because just because they say the pain is 10 out of 10, let's be honest, a hangnail is not a 10 out of 10 pain. Anyway, I digress. And then we also want to know prior history, specifically cardiac. I don't need to know if you stubbed your toe, but I would like to know if you've had a heart attack before, or a STEMI, or an NSTEMI, or any sort of cardiac events. Now, when it comes to treating ACS, there's the way many of us have learned, which was mono, which is morphine, oxygen, nitro, and aspirin. We've actually realized that this may not have been the best treatment for these patients, so some new evidence-based practices and protocols are being instituted. With morphine, we still give it for STEMI. If we haven't identified STEMI, we still give morphine. This is going to obviously help with the pain, but it's also going to help to lower the blood pressure a little. We did find that with NSTEMIs and unstable angina, the use of morphine actually has an association with increased mortality. So just be careful and maybe hold morphine in certain situations. Now, that being said, if we've given the sublingual nitro and their pain is still present, it's unrelieved, let's go ahead and give them some morphine. They're in pain, give them the morphine. The nitro, which is that first line to open up the coronary vessels, didn't work. Let's give them some morphine. Let's get rid of that pain. Let's lower that blood pressure. With IV nitro, the American Heart Association actually does not recommend the routine use. There seems to be a concern for things like drug-induced hypotension, decreased coronary perfusion, and actual worsening myocardial ischemia, more basically heart death, which, well, we never want that. I will say, check with your facility, see what they're doing. If you're concerned, if you hear this and you think, wait, I heard that this was the case and we shouldn't use morphine in these situations, do a little research, find the articles, show them to your people, or question your physicians, see what they know about things. Usually your younger docs are a little more up to date with the evidence-based practice. Check with those guys, see what they say. So what are the outcomes for these patients? Well, with angina, it's usually nitro and observation, usually about a 24-hour stay in the hospital. We want to keep them overnight. We want to open up the vessels with the nitro, and we want to kind of keep an eye on them to make sure that pain doesn't return. With NSTEMIs, we really lean towards kind of medication management. We're going to give beta blockers, and we can actually give those platelet aggregators, things like Plavix or aspirin, and basically that's to prevent further buildup and further buildup in the blood vessels, in the coronary vessels. If it is a STEMI, there's really only one option here. If it's a true STEMI, they're going to the cath lab. They have a significant blockage. It needs to be opened up with some sort of invasive procedure. So get them to the cath lab. That being said, if you don't have a cath lab, which, look, a lot of Midwest rural hospitals, rural areas, don't have cath labs. I'm in New York, on Long Island. I got 42 hospitals within a 3-block radius, and many of them have cath labs. I'm lucky. If you don't have a cath lab, we can actually consider using those fibrinolytics. Yep, we can actually use TPA for a STEMI. Basically, that's going to break up the blockage, break up the clots. It's actually used more than you guys would think. All right, so a couple of concepts here. You got to know your EKGs, guys. You have to know if you're looking at a STEMI or an NSTEMI. So practice. Look at EKGs. Look at the one I showed you. You have to identify what you're dealing with. When it comes to ACS, we know perfusion is the key. We're losing heart muscle by the second because of the blockage, and we need to know which situation we're really dealing with in order to know how severe that blockage is. And as with anything in the ED, prioritization is key. Get that EKG, get that blood, know the steps to care for these patients. All right, a few key points here, guys. Like we said, you need to know your EKG. You need to know if you're dealing with an NSTEMI or a STEMI, so you need to be able to identify that. When it comes to the meds, you need to determine what meds are needed and which are contraindicated. Know when to give the morphine, when to hold the nitro. We want to know what's blocked. It really depends on your diagnosis, which is going to tell us how severe the blockage is. Unstable angina, the blockage is not as severe as a STEMI. So we want to know what's blocked. The feeling of impending doom. Many patients who are having a full STEMI do say this. I will tell you, if a patient states, I feel like I'm going to die, please do not take that lightly. They might. Pay attention to what your patient's telling you. And, of course, you want to know if you're going to cath them or not. Do these patients need to go to the cath lab? If they do, set them up, give them the meds they need, get them up to the cath lab. All right, guys, thank you once again for joining me. Please check out all the other emergency medicine lessons here on nrsng.com. And as always, happy nursing, guys.